of you probably know that you know, we have a huge chronic disease crisis. Many of the worst chronic diseases that we have are related to obesity, and there are obesity-related chronic conditions. And unfortunately, over time, they're becoming more and more prevalent. We're going to be focusing a lot on prediabetes today, and the prevalence in the U.S. of prediabetes is around 34%. But it's important not to forget that some of the other chronic conditions associated with obesity are also increasingly prevalent, and a lot of these conditions significantly overlap. Now, what causes obesity? I think, many people have the sort of basic understanding that, obesity is often related to energy imbalance. You're eating too much, taking in too many calories, not using enough calories. And, I think for many people in their minds, this is the basic concept they have of why, we have an obesity problem. Unfortunately, obesity is a lot more complicated than this. While on a very simple level, your weight obviously does depend on the number of calories you consume, how many you store, how many you burn up. There are a lot of other factors at play, including biological factors, environmental factors, socioeconomic factors, and social policies, all together sometimes referred to as social determinants of health, as well as behaviors. Now, when we think specifically of prediabetes risk factors, the big risk factors are obviously being overweight and obese, but there are other risk factors, including age. So the older we get, the greater our risk of developing prediabetes. Genetics is another big risk factor. So if you have a parent or sibling who has prediabetes, certain ethnicities, we find a higher prevalence of prediabetes as well as diabetes. And lastly, having had other medical conditions such as gestational diabetes or polycystic ovary syndrome can increase your risk of developing prediabetes and diabetes. Prediabetes itself is a staggering public health crisis. There are more than a third of people, as I mentioned, who have it and who are at risk for developing full-blown diabetes, which we know happens at about a rate of 5 to 10% a year. Most of the people with prediabetes, if we don't do anything, will eventually develop type 2 diabetes. What makes this even more challenging is that many people who have prediabetes don't even know they have it. Now, the interventions for overweight and obesity, there is some overlap between treatment for prediabetes, as these conditions are very closely interlinked. The goal of treatment for those at increased risk, first and foremost, is to lose weight. Now, the foundation for all the many interventions that we have for folks who are overweight and obese is lifestyle change. Even for those people who do end up needing to have more aggressive interventions like surgery to lose weight, and this can absolutely be a reasonable treatment for those people who have class 2 or class 3 obesity. Maintaining the weight that they lose through this surgery does require a dedication to healthier habits. Now, as I mentioned before, it may seem simple to accomplish weight loss, just eat less, be more physically active, but accomplishing these two things can require a host of other changes, from how you shop for food, how you prepare food, to even things like how you cope with stress and how you budget enough time for sleep. For way too many years, if you were overweight or obese, you'd go to your doctor and they'd tell you don't eat so much, eat more veggies, start exercising. And unfortunately, in today's healthcare system, most primary care providers just don't have enough time to do the kind of counseling they would want to do, which means that if we rely on them, we'd really be in trouble. It wasn't until pretty recently that clinical medicine made some important strides in how we can promote effective lifestyle change. Now, behavior change is the standard of care for many, many chronic conditions. And if we had a lot more time, we could talk about how important it is for many of the related conditions. But for the purpose of today's talk, we're really going to talk about the diabetes prevention program. Many medical societies support behavior change across the spectrum of chronic conditions, whether it's hypertension, diabetes, and certainly prediabetes. Now, the reason why the diabetes prevention program specifically was such a landmark study was that it really was the first time that in a very robust randomized control trial, this was a trial with 10 years of follow-up, a multi-center randomized control trial that compared intensive behavioral counseling for lifestyle change with placebo and metformin, which many of you know is a medication that's used for people with diabetes or at risk for diabetes, and which is associated with weight loss. They found that intensive behavioral counseling for lifestyle change was more effective than placebo, was more effective than metformin. And that overall in the study, they noticed a 58% reduction in the incidence of type 2 diabetes in people who are at risk for it. Further, they found that if you look specifically at the amount of weight loss that people had in the program, each percentage of weight loss was associated with an increase in the decreased risk for developing diabetes, meaning that for each percentage of weight loss that someone lost in the program, their risk was roughly reduced by about 10% of developing type 2 diabetes. Now, not only was their risk for diabetes decreased, but they also noticed that these changes were associated with a host of other changes in people's cardiometabolic health. So they noticed a decrease in blood pressure, an improvement in lipid profile, a decrease in markers of inflammation like CRP and fibrinogen. So this was a really landmark study, got people very, very excited. And I know for many of you, this is going to be a review because you know all about the diabetes prevention program. I'm going to talk a little bit about how the DPP was structured. The basics included a curriculum. So there was a CDC-approved curriculum that covered some basic topics around healthy eating, physical activity, and stress management. The curriculum was sort of taught by a lifestyle coach, and this was someone with a bachelor's level education who had an additional two-day certification to teach the program. And this would involve coming to a class. So you would come, with a group of people. You would work with your lifestyle coach at each one of these roughly hour-long sessions, and people would have interactions with other folks in the group to talk about challenges that they're encountering and trying to change some of these daily habits. This did require a time commitment. So for many people, coming once a week for 4 to 6 months, could be quite a challenge. And a lot of these programs were traditionally located in clinics, hospitals, YMCAs. Now, I mentioned some of the limitations. There are quite a few. Probably the biggest, and I think probably the biggest for all of you, is really access. Having to show up in person for a diabetes prevention program, can require driving long distances, and it's frankly just impossible for some people. COVID-19 has obviously made this even more challenging. One of the things we've learned is that in-person DPP programs across the country are either closing down, they're either doing their best to sort of move into our virtual environment, and many are just sort of indefinitely postponing their classes. Now, eligibility for a diabetes prevention program was pretty basic. You need to be an adult, meet certain BMI criteria, so be overweight or obese, and have one qualifying risk factor. So you either have prediabetes, so a known diagnosis of prediabetes, or you score greater than or equal to 9 on a prediabetes risk screening test. And there are a couple versions of this test, both of which are available online. There's a CDC risk screening test that you see on the left, and there's a newer screener that's very, very similar. It was co-developed by the ADA and the CDC. Basic idea is to try to help identify those 80% of people who don't know that they already have prediabetes, since, as I mentioned, so many people don't even know they have prediabetes. So I know I speak really quickly, and I want to pause for a moment to see if there were any questions from the group. Jess, any questions I can address before talking a little bit about our program?
No, I don't see any questions.
All right, I will proceed. So Omada's mission is to inspire and engage people in lifelong health one step at a time. And, we've been doing this now for for about 8 years. We've had about 300,000 people go through our program. We have quite a few people that we work with across the country, large employers, state governments, states, large health plans, the VA, and we are actually the largest CDC recognized DPP program in the country, whether digital or in person. One of the reasons that we've been able to do this is that we are closing a really big gap in the ability to provide these programs. And I think the other reason why we've been able to fill this need is that we have recognized that even though there's a proliferation of digital programs out there, when we have talked to people in our program, what we see is that most people really want to still work with a person when it comes to their healthcare. No matter how good technology is, people really want, human support. And so this has been sort of validating for what we do and how we've developed our programs. And I'll talk a bit more about the specifics of how we've done it and how we've adapted the DPP program. But some of the specific ways that a digitally delivered program can really improve upon the DPP is probably first and foremost access. Being able to access a DPP program when you want it, when you're able to access it, is incredibly helpful. But in addition to it, the ability to be able to use certain technologies like connected devices, the ability to personalize the program, and the ability to scale the program and use data to better inform how you coach, all of these things really can make a digital program in many ways a lot more effective. So Omada's program has a lot of similarities with the DPP. In fact, our program obviously is a certified DPP program, but we've really built upon the framework of the DPP. So just like the DPP, it's structured with higher intensity coaching for the first 4 months of the program, followed by 8 months of skill practice and skill consolidation, where participants throughout this whole period have access to the same dedicated coach who works with them, as well as a peer group who can help support them and provide additional accountability. Now, one of the ways that we're able to achieve some of the outcomes that we have in our program, and I'll be showing those a little bit later, is our approach to behavior change, which is obviously one of the most challenging things that anyone can ever do. No matter what kind of behavior you're trying to change. Behavior change is the foundation of all of our programs, whether it's our diabetes prevention program or diabetes program. So one of the big questions we get is, well, how do you actually change people's behavior? And this is something I like talking about because I think, healthcare providers get various amounts of training in behavior change. I know for one, as an internist, I unfortunately got very little training in my training program around behavior change. But one of the core aspects of getting folks to change their behavior is really focusing on what we call autonomy and intrinsic motivation. So this is building on someone's their own motivators in making behavior change. One of the things we've learned from folks who try to use incentives is that external motivators or financial rewards, while they can get people to do, make small changes, you can financially reward someone for getting their flu shot, but those kinds of incentives don't work for long-lasting behavior change. When you remove the incentive, people tend to stop the behavior that you're trying to incentivize. The next thing is skill building. Many people will have a hard time sustaining a new behavior because they don't have a lot of confidence in their ability to maintain some of those changes. A lot of the folks who enter our program have gone through programs like ours. They've either tried to lose weight many times before and they've not been successful. And so many people just don't have confidence in their ability to make these changes. One of the ways that our program overcomes this is by setting really small, achievable goals that allow people to start to build confidence in skills that they're able to master before moving on to even bigger goals, bigger skills. The next is social support. So we ask very early on what kind of support people have, whether it's, who's supporting them at home, who are people that may be sabotaging their efforts to change their behavior at home, and really start to help people understand the importance of social support in their own lives. The next thing we do is address barriers. So there are a lot of things that can make it difficult for people to change their behavior, whether they're environmental, social, emotional. Obviously, COVID-19 has created a tremendous number of barriers for folks to change a lot of behaviors. You know, I know that social distancing practices are sort of different in different locales, but I think just, you know, nationally, we've seen a lot of folks in our program saying that this has created a lot of new obstacles. So one of the ways our program helps people is to, you know, provide guidance for how they can still stay healthy if they're social distancing, or if they're, you know, relatively quarantined. What kind of exercises can you do at home? How can you shop on a budget if you have financial concerns? The other way that we're really able to do this, and we're able to promote lifestyle change, is through our coach training. So I mentioned that traditional coach training for the DPP is really just a 2-day certification. You know, after years of doing this at Omada, we realized that to coach effectively actually takes quite a bit more training. And so all Omada coaches undergo 16 weeks of training. And we have DPP master trainers who supervise this. And the training is actually quite broad. It goes well beyond what the DPP and the CDC require for training. So we do extensive training on motivational interviewing, but also training on how to get people to be physically active. We also spend a lot of time on creating resources for our coaches to continue their education even before even after they've gone through their 16-week training. So we have continuing education for all of our coaches. All of our coaches are trained to really focus on developing a relationship, an empathetic relationship with our participants, you know, trained on how to facilitate positive group interactions, and obviously how to use the technology in our program to really facilitate people's progress through the program. Further, all of our coaches have supervision by a health coach manager. Managers are regularly reviewing progress of people in the program. They help sort of troubleshoot difficult cases. And so, you know, this is an area where Omada has done quite a bit of investment. We recognize that as fantastic as our technology is, we really need our coaches to make this program succeed in the best way possible. So I want to actually show you what the program looks like and show you what it looks like for someone who's starting the program, but I want to pause here again to see if there are any questions. Jess, any questions from the group?
There were a couple of questions in the chat, but we took care of them there.
Okay. All right. So I'm going to, let's see here. To review, the program goals for our prevention program are essentially completely aligned with the DPP. We aim for folks to get a 5% weight loss and to sustain that weight loss through sustained behavior change with healthy eating, increased physical activity, and improved stress management. You know, just like the DPP, we rely a lot on coaches to facilitate people's progress through the program. Where we build on the DPP is in how we use the data that folks give us. So we're able to take how people go through their lessons, how people are using, you know, tracking their food to give them very personalized feedback very, very quickly. Just like the original DPP, we have peer groups that people can interact with and send messages to. And really the goal of our program is to keep people engaged in lifelong behavior change. Now, providers often have a lot of questions about evidence and outcomes. And actually, when Omada first started, these were most of the questions that we got because, you know, we were one of the first people to provide a virtual DPP program. There are a lot of outcomes in our program that we are interested in. And, you know, as you saw from the original DPP program, you know, even though our main focus tends to be weight loss in the program, and that's the outcome metric we focus a lot on, we know that folks who do well in our program do well across a spectrum of outcomes, whether these are clinical outcomes, behavioral outcomes, occupational outcomes, and even, you know, patient-recorded outcomes like just overall well-being, mental health care, and overall life satisfaction. Omada's approach to research has always been to use the most rigorous research practices that we can to track against gold standard metrics, and always to try to report on outcomes using clinically meaningful time points, meaning, we always try to use standard study designs, we use standard metrics, and we publish outcomes at time points that seem reasonable. Good research takes time, and since the very start of our program, we have been interested in understanding how our program works across a diversity of populations. We've also been very dedicated to understanding how does our program work in the long term, which is why we've studied outcomes in our program up to 3 years. I'm going to go through some of these outcomes, starting with long-term outcomes, because this tends to be the first question that people ask is, do the outcomes last? And what we've seen in our program is that they do. Folks in the first year of the program tend to lose about 5% of their weight, and people will maintain most of that weight loss into the second year. People do regain a little bit of it, but they do tend to keep most of it off. When we look at A1C, those folks who start in the prediabetes range will lower their A1C into the normal range and sustain that into the second year. For any of you who want to see any of these research studies, I can send you the full research publications. Just let us know and we can send those over. We've looked at our program and how well it does in veteran populations and found very good outcomes in the veterans populations. We've also looked in seniors. So there were a lot of questions about whether seniors could engage in a digital program, and actually this has been our most successful cohorts were seniors. We found that they had better weight loss outcomes than any population we've studied so far. So, at 6 months, about 8% average weight loss that was sustained at 1 year. And as I'm sure a lot of you know, seniors are actually at increased risk from the complications of prediabetes and diabetes. So, these kinds of weight loss outcomes are tremendously important in this population. Another question that we get very frequently is, how well does your program work for the underserved? And we've seen similar outcomes in the underserved population. Omada actually adapted a version of its program for a lower literacy population, and we've seen very good outcomes in these populations. Another question we get is around dispersed workforce. How well do we do with folks that are working all over the country? And same thing, same kinds of outcomes, kind of across the board. The next question we get is, how does our program compare to in-person programs? This was one of the first questions we got. Interestingly, the VA did its own study. So they looked at their own in-house program for weight loss, which was called MOVE, and they compared it to an in-person DPP program and to our program. And what they found was that engagement was higher in Omada's program, and outcomes were equivalent or better in Omada's program. And given what we've already talked about when it comes to access, this shouldn't be surprising. When people are able to access a program at their own convenience, it makes it much easier to stay engaged with the program. Our last study, and this is probably the one I'm proudest of, is our PREDICT study. So Omada is conducting the largest randomized control trial that has ever been conducted of a digital DPP program. We are going to be publishing our outcomes from this study later this year. Can't talk about the outcomes because it's a randomized control trial, but happy to share those once they're available. Another question that we get, and I don't think providers necessarily think as much about it, but a lot of our employer customers ask questions about it, and which is, what are the economics of prevention? I think most providers sort of know this intuitively, which is that it pays to invest in prevention, and that investing in prevention is very worth it. We did an economic or claim study with Dow Chemical, which is one of our larger customers, and they found that folks who were engaged in the Omada program had overall lower healthcare costs. And the reason why I'm showing this to you, a group of providers, is one of the more surprising findings, and this is actually a finding that we've seen across other claim studies that we've done, which is that a large share of the cost savings came from a reduced spend in inpatient spend, so decreased spend on hospitalizations. This was never something that the DPP program was designed to do. The outcomes that folks looked at were incidence of diabetes. But surprisingly, what we found in multiple claim studies, across the country is that people who are engaging in lifestyle change are overall just much healthier. They're less likely to go to the hospital for all of those other obesity-related conditions, many of which I didn't list. Many of you may know that obesity is not only associated with increased risk of cardiometabolic disease, but also musculoskeletal conditions. So, knee pain, back pain, these are common things that will drive people to the emergency room or the hospital, or even things like, gallbladder disease, cholecystitis. Losing weight can decrease your risk of that. So there are a lot of additional benefits to weight loss that go well beyond the narrow scope of just prediabetes and cardiometabolic risk. And it's worth keeping those in mind as you think about, well, what are the benefits of referring someone to a program like this? So let's talk about how to refer people to the Omada program. So I went over the eligibility criteria. You need to be an adult. You need to have a BMI of 25 or greater, 23 or greater if of Asian descent. And as I mentioned, have a qualifying factor, either a diagnosis of prediabetes, and that can be, a diagnosis that someone gets through a hemoglobin A1C test, through a fasting, a glucose test, or a sufficiently high score on the prediabetes risk screening test. There are some conditions that are exclusions for Omada's program, and the general principle behind these are that number one, someone doesn't meet the eligibility criteria. The other is that the program might not be safe for them. The third is that they may not be able to participate for physical or psychiatric reasons. And the other reason is sort of weight gain and weight loss that may be unrelated to our programs. Some people can stay in our program, despite having some of these, exclusionary conditions, which I'll go over shortly, if they get a medical clearance form from their primary care provider. I'm happy to share this longer list of exclusionary conditions for those who are interested. The basic idea is that, I'll go through these fairly quickly. Folks who are currently pregnant, we don't want folks necessarily engaged in a weight loss, DPP program like ours, just because the weight gain that they have associated with their pregnancy is normal and expected. But within 4 weeks postpartum, folks are welcome to sign up for the program, and they can be referred to our program. People who have eating disorders like anorexia or bulimia, some of the content in our program can be triggering for these people, and it's not always the best match. So we do want people, if they have had these eating disorders, to make sure that they've had treatment, that they've sort of gone through treatment already. People who have substance abuse issues that impair their ability to go through the program often make it not a good match. People who are not able to be physically active, if they have an upcoming elective surgery, for example, and they're not going to be able to be physically active, or they're going to have certain dietary restrictions, that may not be a good match. Folks who've had a recent MI or heart attack or stroke, many of these people should be getting cardiac rehab before they start a program like ours, which is why we have a 3-month window. And then there are sort of a host of other conditions that you'll see on the right. So recent gastric bypass surgery, organ transplant, folks who are undergoing chemo or cancer-related surgeries, folks who are on dialysis. In general, we find that these exclusions are fairly uncommon, and we do ask about them during the application phase. So if you're not sure, you don't have to remember what these are. We'll ask these questions during the application phase. And if someone's not eligible, we'll let them know. And like I said, some people will still be able to start the program even with, some of these conditions if they're able to get a medical clearance form from their provider. So how specifically do you get folks into the program? So this is where I will sort of lean on Jess and other folks to correct me if I misspeak here. But outreach is going to direct residents to your state's unique landing page. So when they go to omadahealth.com/Alaska, they're going to see a website that invites them to take the risk screener test to see if they might be eligible for the Omada program. And they can also find a link to this on Alaska's DHSS website. Anything that anyone wants to add about how to refer folks into the program beyond this? I think this is the latest info that we have here.
Yeah, I'd like to add something. This is Mary Schneider. Can everybody hear me?
Yes.
Yes, okay. So my name is Mary Schneider. I work with the state. I manage the Diabetes Prevention and Control Program there. And thank you so much for your really great presentation. I think it was really useful to have people kind of learn a little bit more about the Omada program. And I just wanted to kind of step back and take a big picture and mention that really overall what we're trying to do is reduce the prevalence of diabetes in Alaska. And Dr. Turkin kind of went over the science behind the diabetes prevention program and saying how it works. And so really what we're doing is we know that there are some diabetes prevention programs available in Alaska, but there's a lot of areas that don't have access to anything. And so through CDC funding, a grant from the CDC, we were able to partner with Omada Health to make this program more available to folks in rural Alaska or anyone in Alaska, even if they live in Anchorage and have transportation issues and can't get to an in-person program. But really the overall goal is to get more people participating in the diabetes prevention program so that we can reduce the burden of diabetes in the state. And so this program that Dr. Turkin went over today is available for any Alaska adult that is eligible based on that prediabetes risk test and the risk test you go through when you go to Omada's Alaska page. And like he said, you can get linked to that page to enroll or to refer participants to enroll by going to diabetes.alaska.gov, and he's got it pointed right there on the screen. If you click there, it'll take you to the Omada Alaska specific landing page, and I'll include a link in the chat box as well. I just did want to mention that you can't just Google Omada Health and then click on that and then try to enroll in this program that is kind of specific to this project that we have here in Alaska. You do have to use the Alaska specific Omada Health landing page, which is posted there, omadahealth.com/Alaska, and I can also put it into the chat box. But you do have to use that specific link to be able to enroll for free through this partnership with the Alaska Diabetes Program and Omada Health. And I know that there was a mention of what about people in rural areas that don't have access to internet, and that's a very valid point. So I did want to mention it. We didn't really talk about it in this presentation or this webinar today, but there is another program that's offered over the phone, so people can participate over the phone even if they don't have internet. And that's through a partner of ours called Inquisit Health. And if you go to our diabetes.alaska.gov page and scroll down a bit and find that link on the left says Diabetes Prevention Programs, you'll find more information about the Inquisit Health program on there. And if you have more questions about this, again, my name is Mary Schneider. I manage the state diabetes program. And so I'll put my email in the chat box. Feel free to reach out to me if you have any questions about the program or you're curious how you can make more use of it for patients that you're serving. Or if you're interested, I can mail out some hard copy flyers that you can share with patients or make available in the clinics that you work at. So I think that was all I had to mention. I know there's questions coming in the chat box. So I see a question. This is Mary again. Is this paid for by the state? The web link says that if you apply and are approved, your health plan or employer will cover. So how does that work? And that goes back to, how, like I said, if you just Google Omada Health and click on that top link, it's going to take you to their own page that is not specific to this project here in Alaska. Typically, Omada partners with employee health plans, and so when you go to Google and you just click that top option, it's probably going to take you to the regular website where, like I said, they are typically partnering with employers, but we've partnered with them at the state level here using CDC funding. And so you have to use that specific link, that omadahealth.com/Alaska, and you won't have to put in any information about a health plan when you enroll through that link. This project, I see, how long is this project funded for? So the state diabetes program is funded through a CDC grant. Like I said, it is a 5-year grant, and we are finishing up year 2. So if all continues to go well, this was the first year that we made the Omada program available here, and we've been pretty happy with it so far. And so if all goes well, we expect to continue to fund this program and make it available through the end of this grant, which like I said, we're wrapping up year 2, and so it's a 5-year grant. I see a question, is this only for pre-diabetic patients? So Dr. Turkin, I think you might be better suited to answer that.
Yeah, so it's a great question. So what I would say is, yes, this program is intended for those with prediabetes. What I would also say is that so many people don't know that they have prediabetes, that the vast majority don't, because they may not have had a recent blood test, an A1C test, or a fasting blood sugar test. That, if you have concern that someone has prediabetes, or that they might be at risk, based on, if they have a family history of diabetes, or if they're, older, if they're, even just, obesity itself is a very, very strong risk factor for prediabetes. So I would, my recommendation is usually to have a low threshold for referring people. The reason being that when you refer them and they go to that risk screener, it takes less than a minute to complete. If they're not eligible for it, they will be told, based on the the risk screener, you're not at high risk. So I would say, don't count on necessarily knowing that someone is has prediabetes. That said, if you're taking care of someone and you have a recent A1C test for that person that has them in the normal range, that may not be the best person for this program. Even if you might otherwise think that, hey, this is someone who could stand to lose a little bit of weight or could use some help being physically active. The program is really geared for those folks who do have prediabetes or are at high risk for it. I hope that helps answer the question. Any other questions? These are much shorter resources. They're designed to be completed and for people to really take these in very quickly. And they're much more sort of narrow topics. But coaches can send these and do send these very, very frequently throughout the program. So someone may say, hey, I'm interested in high fiber foods. What are good high fiber foods I should think about? So coaches can send these 1 to 2 page resources for people, and they do throughout the program. Let's see here. Other questions?
We've had a number of questions in the chat, but I think that we have taken care of them there.
Okay. Well, like I said, if anyone has questions about the program, wants to learn more about either the DPP, more broadly, Omada's program more specifically, I am so delighted to be able to talk to you about the program, and I'm happy to, send our studies as a follow-up. If having another webinar like this would be useful in the future, as a refresher, happy to do that as well. I think prevention is one of these areas where I think we all know that it is worth doing, and we all want to do it. It's just, it's something that it's not as, it doesn't necessarily have the same sort of instant gratification of other kind of interventions that we do as providers, whether it's, prescribing medications or, other diagnostic tests. But I think, having access to a program like this is something that, I never had for many of my patients. And one of the reasons why I decided to join Omada was I found that in my primary care practice, I was sending people to Omada because I didn't have time to counsel my own patients in the way that I wanted them to. And I found that they were having such good outcomes in Omada that, a position became available at Omada, and I said, okay, I have to be a part of this. So, encourage all of you, if you have, questions about the DPP, interest in it, feel free to reach out, I guess, to Mary, to reach out to us, and we're always happy to help in whatever way we can.
Great. Well, I think we are at the top of the hour. Thank you, everyone that participated. I hope this gave some good insight into the Omada program and how you might be able to use it in your practice. Again, if you have any questions, please shoot me an email, and I would be happy to send more information. And we will work to get this webinar recording posted on our website at diabetes.alaska.gov. So you can check back there if you're interested in the recording. Thank you guys for participating. Thank you, Omada, and especially Dr. Turkin for presenting today. And I hope you guys have a wonderful day.
Same to you, and thanks again.
Thank you, Mary.